Good morning, everybody, and thank you very much for joining us today. My name is Austin Willett. I'm CEO of Different Strokes, and welcome to the latest in our 2023 webinar series. If you've attended one of these that we've previously run this year, it's fantastic to have you with us again. If you're joining us for the first time, it's great to see you here. We're running these webinars every few weeks throughout this year, so please do keep an eye on our website and our socials for details of future sessions that we'll be putting on. Today, I'm delighted that we're joined by Katie Mahoney, who is lead physiotherapist with Odstock Medical Ltd. Katie will be talking today about functional electrical stimulation, and I know from the numbers of people who've signed up for the webinar and the huge amount of questions that we've had come through in advance, that it's going to be a fantastic session today. Before I hand over to Katie, just a little bit of housekeeping. This session is being recorded, but I must stress that no details of the people who are viewing the webinar are being captured, and the only people who will be appearing on screen are myself and Katie. We do have a chat function, so I can see people have been busy with that already, which is great. So please do that to say hello to us. Let us know where you're watching from. Already I see we've got someone who's watching from Australia, which is fantastic. But let us know what you're watching from, and if you've got any general comments, please do use the chat function for that. In addition, we have a Q&A function. So if you do have any questions, please do pop them in the Q&A function, and I'll do my best either to answer them as we go, or time permitting, and to see if Kate is able to answer those questions at the end. If I could stress though, please, that if you do specifically have questions, to use the Q&A and not the chat, as they might be missed if they're in the chat. Anyway, with no further ado, I'm delighted to bring in Katie and introduce Katie. Good morning, Katie.
Good morning, Austin. Thank you for the introduction. And welcome everybody. So my name's Katie. I'm a physiotherapist at Odstock Medical, which is based in Salisbury in the UK. So we provide FES, functional electrical stimulation, which I'll tell you a bit more about in my presentation. So I'm a physiotherapist by background, and I've worked in sort of stroke and neurophysiotherapy for the past few years. So we'll start my presentation. Okay. So I'm going to talk about FES. So I'm going to explain what OML is and what FES is. I'm going to talk a bit about who FES is suitable for, the different ways in which FES can be used. At OML, we mainly concentrate on upper and lower limbs, so that's what I'm going to talk about in this presentation. I'm also going to cover some of the evidence and clinical guidelines for the use of FES. They focus mainly on the UK and Ireland guidelines, but I can see there's an international audience. I'm going to talk about funding for FES and how you can get more information on it if you're interested. So first of all, what is OML? So it's Odstock Medical, which is a company that started at Salisbury Hospital in the UK. It grew from there and became Odstock Medical Ltd in 2005. So we're the UK's leading provider of FES devices and also clinical treatment. So the devices have been designed here at Salisbury Hospital through collaboration with some of the engineers and clinicians, and also our patients here. We provide clinical services to those patients. So we support patients with the devices for as long as they're using them. We also offer training courses to clinicians, so to teach them in the safe use of FES, to help spread FES really to a wider audience. So what is FES? Some of you might already be aware of it and might have tried it, but for those of you who haven't, it's a treatment that stimulates the nerves using small electrical impulses. So it can be used to help restore normal movement to muscles that have become weak or paralysed after damage to the brain or spinal cord. So for example, after stroke. It can also be used for quite tight muscles if there's high tone, to help sort of stretch them out and relax them. In the picture here, I've got the main two devices that we use. So we've got the lower limb device here, which is called the ODFS Pace. And then on the right, we've got the microstim device. So who can FES help? The short answer really is almost anybody after stroke. So the main criteria is that your weakness is caused by an injury to the brain or upper part of the spinal cord, so at the cervical or thoracic levels. Below that level, the spinal cord changes and it becomes peripheral nerves, which means that it's generally we can't stimulate it. There are always some exceptions to that, but on the whole, it wouldn't work for people with a lower spinal cord injury or an injury to the leg or arm itself. So it can work for people with both hemorrhagic and ischemic strokes. The main people who can't use FES, as I said, if your weakness is caused by an injury that's kind of in the arm or leg or sort of in the lower back, if you have fixed contractures, so by that I mean if your joint is absolutely fixed, rigid, and you cannot stretch it out at all, then FES is unlikely to help unless it's been combined with sort of splinting and possibly surgery to help relax the muscles. If you have cardiac issues and you've got a pacemaker device, then FES isn't always suitable for you. So we need to do an assessment when we first try the FES on you, we do it alongside a cardiac physiologist so they can test the function of the pacemaker. So if you do have a pacemaker or an implantable device, then yeah, make sure you're being assessed with a clinician and a cardiac team there. Also, if you have a history of seizures, you can still use FES, but we generally want somebody to be stable for 3 months before starting treatment. So I would advise speaking to your clinician before you have an assessment for FES. Okay, just say there are a few other precautions and contraindications, but those are the main ones. So going on to the main uses of FES now. The biggest area that FES is used in is for foot drop, and I'll explain a bit about foot drop and show a video of it in a moment. That's where most of the evidence is, and that's where yeah, the biggest use is. But it's also used to help other muscles in the leg, either in walking or it can be in sit to stand practice. So those might be muscles like your quadriceps, your hamstrings, or your gluteal muscles. So kind of bigger muscles in your leg to help keep you upright. It can also be used in the arm. So to improve the strength and function in your arm after a stroke. If you've got a little bit of movement there already, it can help to build on the strength and the movement that you've got. It can also be used if you've got a lot of tightness in your muscles after stroke. So alongside medication and sometimes Botox injections, it can help to manage that tightness and relax your muscles a little bit. So I'm going to go on and talk about FES for foot drop now. I'm going to start with a video. So this lady is walking without FES to begin with. So you can see she's got right hemiplegia, and she's got what we call foot drop on her right side. So her right ankle isn't lifting very much. Her toes aren't lifting. She's not getting much dorsiflexion at her foot. She's now walking with FES and she's getting better dorsiflexion, a longer stride length and heel down and better heel contact. She's also walking much more quickly, much more confidently. Just play that video once again. So you can see she's finding it difficult to clear the floor. She's stepping her foot to the other one. She's also very focused on the floor and looking down. So now with FES on, it's coming on when she's trying to step her foot through, and that's helping to lift her foot and enable her to get a longer step and walk more confidently and more safely. Got another video of a lady with, this lady has got a lot more sort of tone and spasticity after her stroke, alongside some weakness in her ankle. So here she is walking without FES to begin with, and you can see her ankle's pulling in. She's landing on the outside of her foot. It's turning inwards. So she's at risk of going over on her ankle. So she's turning her FES on now. And then FES is helping to get better dorsiflexion at her ankle. It's helping to keep her ankle in a more stable position and get better heel contact. So how can you wear FES? You might have seen both of those ladies in the videos had their FES boxes on their waist. There's two sort of sticky pads called electrodes that go on the leg. The position of, depending on where we put the electrodes, will activate different nerves and different muscles. So the positioning of those electrodes is really important, and it will vary from person to person. So you have the electrode, you have a wire then going up to the box. You also have a foot switch that you can either have with a wire or you can have a wireless version of the foot switch. So the foot switch tells the box when you're taking a step and then turns the FES on and off. You can wear the box on your waist, as those ladies had in the video. There's also the option of a leg cuff, so you can wear the electrodes in the box together in the cuff and wear that on your leg. Okay, I'm now going to talk about the benefits of FES for foot drop. So the main benefits are a reduction in the number of falls, sometimes by up to about 70%. It can increase your speed of walking, and we've seen in the previous videos it can help people to take a longer step, and that enables them to cover more distance and walk more quickly. It can reduce the effort of walking, so it can make walking less tiring. We often find that people are less focused on the floor, so they're able to look up around them and they're not having to concentrate quite as hard on lifting their foot. If people have a lot of tightness in their muscles, it can help to reduce that tightness and stretch out those calf muscles. It helps people to feel more confident about their walking, and people often report in clinic that they feel more confident that they can complete a walk that they undertake. They report feeling like they have a better quality of life because they're able to go outside and walk on more uneven surfaces. Then they're able to hold a conversation sometimes whilst they're walking rather than solely focusing on their foot. And it means that they're better able to participate in daily life or activities of daily living. Some people with FES will see what we call a training effect. So they'll see that their FES helps to strengthen their muscles and improve their walking. So even when they're not wearing their FES, they'll still see improvements in their walking long term. So they might see that their foot lifts better. They might see that they can walk faster, and that their overall walking has improved. Not everybody sees this. Generally, out of all our patient groups, it's about 20%. And it generally, if it happens, it will often happen in the first few months of starting FES. But for everybody, FES can be used in place of a splint if you want it to be. So it can be used as a sort of long-term mobility aid. Okay. I'm now going to talk about the guidelines and the evidence for FES in foot drop. So back in 2009, FES was first highlighted in the NICE guidelines, and it recommended foot drop as a treatment for people with foot drop, provided that they were being suitably monitored and people had been informed about the treatment and they understood what was required. Much more recently, earlier this month, the Royal College of Physicians brought out the National Clinical Guidelines for Stroke for the UK and also Ireland. And that recognised FES again as a treatment for people to help with walking and also to help with reducing falls and improving balance. So people after stroke should be considered for FES or have access to it if they wanted to. There's also the ACPIN guidelines. So ACPIN are the Association of Chartered Physiotherapists in Neurology. So they're based in the UK, and they put together a clinical practice guideline. So it's predominantly to support clinicians, but it also makes the point that people shouldn't just be given an FES device and left with it. They should have long-term follow-up and support with their device, because often changes and adjustments need to be made to the settings. There's also I think it's 2021, in the clinical practice guidelines for the use of AFOs and FES over in America in the Academy of Neurological Physiotherapy. And finally, there's the NICE guidelines, which are due to be reviewed shortly, or in the process of being reviewed now. But the last ones were released in 2013, and they also recommend FES as a treatment for foot drop following stroke. Okay, so I've talked about FES for foot drop. I'm also going to talk about FES for the arm now, for the upper limb. So it's most commonly used for the arm, and you can see in the picture there with electrodes on the forearm, and that stimulates the muscles that extend the wrist and extend the fingers. And you can see in the picture, this is with FES turned on, so you're getting extension at the wrist and extension at the fingers. So it can help with strengthening these muscles as part of a kind of a rehab program post-stroke. It can help to improve the strength and the fatigue resistance of these muscles. So if you're able to move your hands a little bit, but you find that that your muscles fatigue very quickly, FES can help you to get more repetitions and higher amounts of practice in during the day. It can also help if somebody's got quite significant weakness in their arm and a lot of muscle tightness. And it can be difficult sometimes to get to the palm and the hand. FES can help alongside stretches and medication with stretching out the hand and making it easier to wash and clean the hand. FES will also increase the blood flow to the limb, so it can help improve circulation, improve your skin condition, and it can also reduce pain, both by improving circulation and getting some movement in the muscles and joints so they don't become stiff. FES can also be used for the shoulder. I was hoping to have a video of this, but I couldn't get it to work. So you can place electrodes over the shoulder, and if somebody's got what we call subluxation, so their arm feels very heavy and you can feel a little bit of a dip at your shoulder, it can help to activate those muscles and sort of bring the arm back up so it's nice and snug in the shoulder socket, and that can help to reduce pain. In terms of guidelines for the upper limb, the main one is the one that was produced earlier this month. So on the whole, there's been less high quality evidence to support FES in the upper limb, but that's changing now, and FES is supported for people post-stroke who are unable to lift their arm against gravity. So if you can lift it up in the air, it's generally better to practice those active exercises. If you can only lift it a little bit of the way and it's harder to move it, then that's when FES can really help. So the guideline recommends that people with wrist and finger weakness, which limits function after stroke, should be considered for FES on their wrist and finger extensors. The guidelines say that all the stimulation protocols should be individualised to the person with a stroke, both in terms of how they present, in terms of weakness and the movement that they have, and also in terms of what they can tolerate. The person with stroke, their carers, their family, and also the clinicians working with them should be trained in the safe application and use of FES. People with what's called an inferior shoulder subluxation, so where the arm is kind of pulling down a little bit in the socket, who are in 6 months of stroke, should be considered for electrical stimulation. Neuromuscular electrical stimulation is the same as FES. The terms are used interchangeably. Neuromuscular electrical stimulation is when it's used as an exercise mode. FES, strictly speaking, is when it's used in a function such as walking. And finally, the guidelines recommend that if you've got spasticity or tightness in your hand, for those people who've had botulinum toxin injections to help relax the muscles, FES can be useful after that to try and maintain range of movement and strengthen the weak muscles. Okay. I'm now going to play a video. She's one of our patients here called Hannah. So she started treatment with us at the end of last year, so she's very new to FES, but she wanted to talk about and share her journey so far. Okay.
And Katie, we don't really seem to be getting sound through on Hannah's video, unfortunately. So maybe we can pause it, and perhaps if we liaise on that after the webinar, it might be that I can circulate Hannah's video to everyone after the webinar, perhaps.
Okay, this is another video showing Hannah walking with and without her FES. So this one is a lot shorter. So I'm now going to talk about how you can access FES. This is because we're based in the UK. This is mainly focused, or this is focused in sort of access to treatment in the UK. So this map shows, so we've got Salisbury where we're based. It also shows some of the FES clinics. So OML has got outreach centres, which you can see in the list on the left, and they're shown by the yellow stars across the map. There's also other NHS centres, which are shown by the blue stars, and there's a list of them on the right-hand side. It's not an exhaustive list because the centres that offer FES changes on a regular basis, and it's different areas change their policies. So FES isn't automatically funded in the UK on the NHS. In some areas it is, but in other areas it isn't. So it varies by area, and the kind of integrated care boards or each area will also change their funding policy, not just about FES, but about other treatments on a regular basis. So it can be it makes it hard to put together a map or a list of what areas fund FES or not. So we're happy you can get more information on our website, Odstock Medical. If you'd rather, you can phone us, the patient support team will help give advice about whether you can get funding in your area. So you're welcome to speak to us. We will offer a free assessment for somebody to try either upper limb or lower limb FES at one of our outreach centres. And if we are able to apply for funding, we will help you do that. If there's no funding available, then people have the option to pay privately for treatment. We tend to fund things as a treatment package. So you get the device, but you also get the wires, the electrodes, and the appointments with a clinician to help you in adjusting the FES settings. So one thing about FES, it's important to have a clinician to support you with using it. So rather than just being given a device and left with it, to get the most out of it, we find we always need to make adjustments to the settings or to the electrode placements. And that's really important to get the most out of the device, and to over time, people often change. So the strength in the muscles, the tightness in the muscles, the kind of the movement that you've got, you might have medical issues or just general age-related changes that will affect either your hand function or your walking or standing. We'll also help with maintaining the device and sort of troubleshooting if things aren't working. Okay, that's all I wanted to say in the presentation. So thank you very much for listening, and I'm happy to answer any questions now. So
Katie, that was absolutely fantastic. Thank you so much. It's really great to hear about all about FES. We've had a lot of questions come through. We've had a lot in advance, and we've had a lot in the day as well. So I will do my best to start to work our way through these. So, firstly, had a couple of questions on this subject. Firstly, are you saying that lower motor neurons are not suitable for FES? Is that the reason lower spinal injuries might not be suitable?
Yes, it is. So if it's an upper motor neuron lesion, we know that the lower motor neurons are intact. So we can stimulate those with the FES and they'll then activate the muscles. If the lower motor neuron itself is damaged, the nerve tends to atrophy and sort of start to die off really below the level of that lesion, which means that we then can't stimulate that nerve and get a response from it. We do have people with lower motor neuron conditions on treatment, so it's not, you could try FES as a last resort. It's not a contraindication, but it is much less likely to work. So generally we advise it for people with upper motor neuron conditions.
Okay. So in terms of the lower limb, would FES work on toes, for example?
Yes, it can. We can use it to help extend toes, and we often do that in combination with the ankle. So to help lift the ankle and extend the toes. You could use it to activate the toe muscles. It's generally a bit harder to find the placement on smaller muscle groups, but you could use it as an exercise mode, yes.
Okay. Question we had come through in advance. Is this stimulation recommended in early days after complete right side paralysis? This is in reference to, with reference to a patient that's currently under hospitalisation and having daily physio.
So yes, it can be. As soon as somebody is able to start sort of, you know, getting up or kind of moving their limbs, then they could start FES. So there's no time that's too early to use it, as long as they're not medically, if someone's medically advised not to be getting up and moving, then we wouldn't use FES. But as soon as they're okay to do that, they could start FES treatment. Often in the early days, when you're in hospital, there's quite a lot of things. The therapy teams will want to work on people, getting people up and sitting out and sort of establishing communication and that kind of thing initially. So they might not use FES in the very early days. It can often be something that's used perhaps a bit later on in somebody's rehab or when they get home from hospital and they've got a bit more time to focus on it.
Thank you. So I guess the other side of this question is, would this treatment be available for someone who had a stroke 7 years ago and who currently has aphasia and right side paralysis?
Yes, it would be. There's no kind of upper limit on when you can start using FES after a stroke. So as long as you've got weakness or you've got goals relating to FES, then yes, you could use it and benefit from it. And that's what the new RCP guidelines that came out earlier this month said. There shouldn't be an upper limit to sort of stroke rehab. It's ongoing.
Sure. So next question we've had through. I've had FES for my drop foot, but I also have spasticity in my left arm and sublect shoulder. How do I go about getting help for that?
If you are under a clinician for your drop foot, I would suggest speaking to them. Often we use a slightly different device for the lower limb, would normally have a foot switch with it and one channel of stimulation. For the arm, particularly for the shoulder, we often use 2 channels of stimulation, but we don't have a foot switch with it. But that means we can get more muscle groups around the shoulder. So I would speak to your clinician and sort of ask them. They might be able to use the same device that you've got in an exercise mode, or yeah, they might be able to set you up with a different device.
Thank you. We had a few questions come through, I guess, in terms of some timescales and so forth. So, for example, how often should you use your FES device? Is there a recommended amount of time per day that you should use them for, etc.?
Yeah. There isn't specific guidance on it. There have been some research studies, but there isn't any consensus in the literature. If you're using it on the arm for exercise mode, we would generally say if you're using it to try and improve your strength and movement, you would want to tie it in with, you wouldn't just want to do FES, you'd want to tie it in with other exercises, sort of physio occupational therapy and that kind of thing. So it would also depend on how much of other things you were doing. But you could use it for up to about an hour on exercise mode. Sometimes it's better to split that up during the day and do shorter segments. If you're using it to try and reduce tightness in your muscles and to stretch your muscles out, then generally sort of 30 minutes to an hour and once or twice a day can be quite useful for that. If you're using it on your leg to help with walking, you can put it on in the morning and you can leave it on until just take it off at night when you go to bed. So you could wear it all day, but we wouldn't start people off with that because your muscles will get quite sore and achy. So we'd start people off with just short periods, possibly about 20 minutes at a time, and then build up. But again, that's one of the things your clinician can advise you because it's individual to each person. So they can help give you advice on how often you should be using it, sort of when you should be using it and how much you should build up.
Thank you. So in terms of some specific stroke types, we had a question, any research experience with SES for people who've had a massive pons stroke?
Yeah, there isn't research for FES specific to different types of stroke. Most of the research tends to be for stroke as a whole, but that's because it doesn't really, in some ways, it doesn't matter the type of stroke you've had, whether it's a bleed or an ischemic stroke, and whatever area of the brain has been affected, FES will still work for you because it's kind of upper motor neuron. So the most important thing is the symptoms that you present with and where you have the weakness, how much weakness you have or muscle tightness. And that's generally how we would decide what electrode placements to use and how often to use it for. So it's more directed by the symptoms that you have rather than the location or size of your stroke lesion.
Thank you. Loads of questions are still coming through. If you're happy to still, it's obviously a real key area, this where people have got lots and lots of queries. So a couple that I'll take together. Is FES available to people who've had it before? And on a similar vein, thank you. If we have already been funded for neuro rehab, which is finished, could this also be funded?
Yes, you should be. At Odstock Medical, we will see people who've had treatment before and they might have stopped for whatever reason, but if they then want to restart again in the future, we would see them again because people change in their recovery period. Also, their situation changes. Sometimes they might be working, they might not have a lot of free time. They might then go part-time at work and have more time to spend on their rehab, or they might have carers or family who can now support them, whereas they couldn't previously, and that might help them to set up and use their FES more. They might have just improved their function and their walking and just be able to get out and about and use FES more. So we're always happy to reassess people and see them at a different time. And that should apply sort of anywhere that you go for FES, really. Each individual service will have their own rules, so and sort of their own kind of waiting lists and that kind of thing. So you would need to get in contact with each individual service, but in theory, there is no reason that you couldn't use it again. And also, if you've had a different sort of neuro rehab treatment, or you've been to a neuro rehab unit, you should still be able to get access to FES. So as long as you have goals that FES will help to meet, there's no reason that that treatment shouldn't be funded as well.
Thank you. Leading on from that, I had a couple of questions on the costs. So how much does a unit cost? Also, how much would it cost to pay privately?
So it varies between upper limb and lower limb. When at OML, we tend not to get, people don't buy their devices generally, so they loan them from us, and that loan comes as a package with appointments, also all the what we call the consumables, so like the wires and the electrodes, the foot switches. So that's all included as one package. We'll also repair and maintain the device, and they've got customer services to help them. Sorry, there's a helicopter just flying past.
Right. I mean, I would suggest if anyone's interested in looking at this, the best thing for them to do would probably be just to contact you directly. And
yeah, you can contact us directly and we can give you information, because some areas can get funding and you won't need to pay for it. Other areas you can pay privately. Sometimes there are some charities who will help with funding, or pay some of the fees. That's sometimes an option. You might also, the upper limb devices are a bit more straightforward to use. So if you've got your own physio who's familiar with FES, you can purchase an upper limb device yourself. The lower limb devices are more complicated to set up. There's a lot more settings and parameters. So OML will only sell those to a clinician who's trained in setting it up for you, because we don't want you to buy it and not be able to make use of it.
Yeah. Next one. Hi, Kate. Thanks for sharing. I'm a new grad working in neuro rehab. With the FES during the gait cycle, how is the up cycle being modulated with each step? Is this through a sensor, or do you adjust for frequency?
So when you use FES, you're getting it's activating the nerves, the kind of motor nerves that will give you some movement in your foot. It's also activating the sensory nerves. So that will give feedback up to the brain and the spinal cord, and that can help with getting some kind of training of those nerves, and that's the kind of neuromodulation that person is talking about. So when you're using FES in a functional task, so it could be like reaching forwards to get hold of a cup, or it could be in walking. When you're combining it with function and you're thinking about doing that movement as well, you're likely to get, those nerves will fire together better. You've got feedback coming up and also down from the spinal cord, and those nerves, is generally thought that there's greater potential for them wiring together. There's also more research, which is a much newer area, but in spinal cord stimulation, and using spinal cord stimulation alongside traditional FES to try and improve that relearning. So that's an area that's starting to emerge a bit more.
Okay. Thank you. We've also been asked, in your experience, what is the carryover of SES into gait without the device?
Generally, it's there was a study that we did here a few years ago, and for the whole patient group that we have, it was about 20%, but that includes some people with more degenerative conditions like multiple sclerosis or things like that. So on the whole, people after a stroke or a condition that's a bit more stable, where you're likely to see recovery, are more likely to see a training effect, but it doesn't happen to everybody. So it's hard to put a number on it really, and it's hard to predict who's going to see a training effect and who isn't. I think generally if you have a little bit of movement already in your foot or ankle, that can often help. You need to be able to use it sort of every day and use it on a regular basis to have more chance of seeing an improvement. But it's often a case of sort of watching and waiting. But we do tend to see most people, almost everybody, improves their walking speed when the device is turned on. So even if they don't see it when it's off, they will still see some improvement in their walking.
Thank you. I have focal seizures which are controlled by medication. I also have a drop foot. Is this right for me?
Yeah, it can be right for you. So if you generally would want somebody to be stable from a seizure point of view for about 3 months after their stroke. And the reason for that is because we're using electrical stimulation, the theory is that that could change the electrical activity in your brain, and it could in theory trigger a seizure. There isn't a lot of evidence to support that, but we want to be quite cautious with it. So we generally want people to be stable for 3 months so that we can then look and see whether FES has changed the frequency or type of those seizures. If it did, we would stop treatment, but most people, we have quite a lot of people with epilepsy on treatment and they're absolutely fine with it. So it's not a contraindication, you just need to be cautious about it.
Yeah. And in terms of being cautious, we've got a really good comment here. I recently went to test pacemaker with FES to help to understand what's safe, and I highly recommend it. So I guess the message here is, yes, it's really important for these things to be tested and to be checked out, but in theory, there's no reason why you wouldn't be able to use FES.
No, again, if you want to use FES on your leg, you can. I pretty much, I think I've never known anybody who, when we've tested it with a pacemaker, they've been unable to use it. So yeah, so you can use it safely, but you just need to make sure that that the pacemaker doesn't pick up the reading from the FES and think that's your cardiac rhythm, because that's a risk that then your pacemaker wouldn't kick in if you needed it to, because it would think your FES was your heart rhythm. So that's why it's important to test it. But as long as it's been tested with cardiac physiology, then yeah, you can use FES safely.
Just a couple of questions we've had in terms of settings and positions, etc. What are the best settings and setup for dorsiflexors?
It varies a lot from person to person. So earlier in the presentation, I had sort of what we call the standard electrode positions. So we generally put one over the head of fibula on the side of the leg, and then one over what we call the motor point of tibialis anterior, which is sort of on the front of your leg. But it will vary from person to person. So it's best to have an assessment with a clinician who's trained in FES. We have got some videos. We've got a YouTube channel on Odstock Medical, and there are some videos on there with a guide to basic electrode positions. But you often need to change the settings in the device as well as the electrode placement. So I wouldn't, if you try it yourself, if you've got a device and it doesn't work, that doesn't necessarily mean it won't work. I'd say go and be assessed by yeah, someone who's more familiar with FES.
Okay. What, I'm sure this is obviously going to vary, but I'll ask anyway. What are the positioning options for different muscles and device parameters for different goals?
Yeah, again, it varies hugely. So depending on where we put the electrodes, we'll activate different muscles or nerves. So you place those depending on what you want to get. But everybody's anatomy is slightly different. So often the size of the electrode and the position of the electrode will change. You can also, in terms of the parameters, you can change the intensity of stimulation. So if it's too weak, you won't get anything at all. If it's too strong, it'll feel really uncomfortable, but it'll also generally make your arm or leg pull away. You'll get a lot more tightness. So the intensity needs to be at the right level. And we also need to adjust the timing. So if it's for the arm, you don't want two muscles coming on together if they're going to work against each other. And again, if it's for your leg, you want it to pick up your foot just as you're starting to lift it. So there's a lot of different settings to change, and that's why it's individual for each person.
Sure. Was still getting quite a few questions come in. Unfortunately, I don't think we'll have a chance to go through them all, but I'll just ask a couple more. I had a brainstem hemorrhaging stroke in 2018 with left side paralysis. I have no movement in arm or hand. Would it work on muscles which don't seem to work?
If you, it depends on what your goal is with using FES in that situation. So if you're sort of 5 years post-stroke and you've got no movement at all in that arm, it's unlikely that FES is going to regain you significant movement in that arm. You might start to see some improvements, but it isn't a miracle cure. It's not going to, just because the FES can move your hand and fingers, it's not necessarily going to carry over to you being able to do it yourself. However, if your goal is that you've got some tightness in that hand and you want to help stretch it out and move your hand, so it might make it easier to put a splint on, it might make it easier to clean your hand, or just that your hand gets quite stiff and swollen and you want to improve the circulation and the movement, then yes, they're very valid goals for using FES, and you might use it long term. Yeah, it can help to regain movement, but it's not necessarily going to be a miracle. So if you don't have any movement and you haven't seen that for a number of years post-stroke, it's not impossible, but I'd say it's unlikely that it's going to get you lots of movement in your arm, unfortunately.
Thank you. Hi, Katie. Is an ASIA, ASIA, is an ASIA motor incomplete injury contraindicated with FES if the lesion is above T5 or 6?
No, so as long as the lesion is above T12, that makes it upper motor neurone, so it would we'd expect FES to be effective. If it's below T12, and the level varies a bit again from person to person, but roughly below T12, so in the lumbar or sacral region, we wouldn't expect FES to work. It generally, if it's incomplete, you've generally got some movement, so FES will be more effective because it's if it's a complete lesion and you've got no movement at all, then again it's hard to, with 1 or 2 channels of stimulation, it's not going to make a huge difference to your perhaps like your standing or your walking, so you'd be using it with the goal more of improving circulation in the limb and skin condition.
Yeah, thank you. Does it help with clonus?
Yeah, it can help with clonus because it stretches out that muscle. So clonus is very common in the calf muscles when they're stretched. So FES will, either in an exercise mode or if you're walking, it's activating your dorsiflexors, which then stretches out your calf muscle, and it's doing that repeatedly. So it can, as long as you've got the settings right, because it needs to come on quite gently. If the stretch is too quick, it can sometimes make that clonus worse. But if you set it up properly and the settings are quite gentle and tailored for you, over time it will often improve clonus.
Thank you. And I think we'll make this the last one for today. If my purpose is to reduce spasticity, should I put the electrode pad on the spastic muscles or on the antagonist muscles?
Generally, I would go for the antagonist muscles. So, for example, if you've got biceps that are very tight and it's pulling your arm in like this, I would generally say to put it on your triceps, the opposite muscles here, so that it's helping to straighten out your arm and therefore stretch out those muscles that are very tight. You can sometimes put it on the spastic muscles if there's weakness as well. So you can have spastic and then antagonist alternating. But as a rule of thumb, I would tend to do the antagonist unless I guess your sort of physio or OT is, you want to sort of work along, you've got a program and they want to strengthen those muscles.
Thank you. Katie, thank you so much. I feel I've thrown literally hundreds of questions at you. I don't think I've had a webinar before. I've had so many questions come through, both in advance and on the day. There's a number of questions that we simply haven't had time to cover today. But if there are things, if you're watching and there's further questions that you have for Katie, please do email us at info@differentstrokes.co.uk. Would be very happy to forward those questions to Katie. I also know that Katie would be very happy for you to contact Odstock Medical as well, if you've got any questions on that. So I'm sorry, as I said, apologies if we didn't get a chance to cover your question, but hopefully we'll be able to answer that in due course. Once again, thank you to everyone that's watching today. We will be doing more webinars at later points throughout the year, so please do keep an eye on our website and our socials for details of webinars that will be coming up. I'd be really grateful if, when this call ends in a moment, if you're able to stay on and complete the feedback form. It's very, very short. There's only 5 questions. It shouldn't take more than 2 minutes to complete, but it would be great to get your feedback on today. And also, if you've got any ideas about other webinars that you'd like to see us put on in the future, we'd be really happy to hear them from you. But once again, thank you so much to Katie. It's been such an interesting talk, and we really appreciate your time this morning. Okay, thanks everyone. See you all soon. Bye-bye.